In 2019, UnitedHealth deployed an algorithm to decide when Medicare patients in nursing facilities had recovered enough to leave. By 2022, the algorithm had doubled the company's denial rate for post-acute care. 9 out of 10 of those denials were later reversed on appeal. The algorithm kept running. Walk into Medicare open enrollment and you see options. Specifically, the privately run Medicare plan that now covers 54% of every American who reaches 65. You see Aetna and think established, trusted, the name on your parents' insurance cards. You see Humana and think national network, solid reputation, the brand from every television commercial during October. You see UnitedHealthcare and think the largest health insurer in America, the safe choice. You see WellCare, HealthSpring, Devoted Health, and you assume you are looking at competitors who need to earn your business. That is an illusion. 3 of those companies control 60% of every Medicare Advantage plan in America. In 931 American counties, 29% of all counties in the country, UnitedHealth and Humana together control at least 75% of Medicare Advantage enrollment. In 44% of all counties, a single insurer controls more than half the market. The KFF Health Policy Organization analyzed data from the Centers for Medicare and Medicaid Services in 2024 and found that fewer than 1% of American counties have anything approaching a competitive Medicare Advantage marketplace. The choice you believe you are making is not a real choice. In most of the country, it is a choice between subsidiaries. In this video, we are going to expose the 2 mechanisms those 3 companies use to extract money from that position simultaneously, reveal the specific algorithm that decides whether your doctor's recommendation gets honored before a single physician at the insurance company has read your file, and show you the 3 things that remove those mechanisms from your coverage entirely. We will also address something that has not received the coverage it deserves: the structural mechanism that locks 22 million Americans inside Medicare Advantage, even after they discover it is not working for them. To understand what that mechanism is, you first need to know how 3 corporations came to control what was supposed to be a public program. UnitedHealth Group controls 29% of all Medicare Advantage enrollment in 2024, or 9.4 million people. Humana controls 18%. CVS Health, through its Aetna subsidiary, controls 12%. Those 3 companies together cover 59% of the 32.8 million Americans currently in Medicare Advantage plans. The federal government paid those 3 companies as part of the $462 billion in total Medicare spending in 2024. According to the Medicare Payment Advisory Commission, MedPAC, the independent body that advises Congress on Medicare payment, those 3 companies and the industry overall were overpaid by at least $83 billion compared to what traditional Medicare would have spent on the same patients in the same year. That is the amount they collected above what the care actually cost. And at the same time they collected that premium, they were denying access to care at rates that have been climbing every year since 2019. Both of those things are happening simultaneously. The same companies are collecting more and paying out less in the same fiscal year on the same enrolled patients. What nobody who signed that 2003 law anticipated and what the Senate did not investigate for 20 years is what 3 corporations built once they controlled the market. In 2003, Congress passed the Medicare Modernization Act. The theory was to introduce private insurance companies into Medicare, let them compete for patients, and competition would drive down costs while improving care. Medicare Advantage was created. In 2007, 8 million Americans were enrolled. By 2024, that number had grown to 32.8 million, 54% of all Medicare eligible beneficiaries. The Congressional Budget Office projects that number will reach 64% by 2034. What the 2003 law did not prevent was consolidation. Between 2017 and 2024, UnitedHealth's market share grew from 25% to 29%. CVS Health's share grew from 8% to 12%. Smaller regional plans that once provided genuine local competition steadily lost enrollment to the three national platforms that had the capital to absorb them. The resulting market is one in which the financial incentives Congress built into Medicare Advantage, which pay insurers more for sicker patients and reward them for the care they do not have to provide, are now concentrated in three organizations with the scale to exploit those incentives at industrial volume. The mechanism that actually exploits them is the algorithm. In July 2019, UnitedHealth Group deployed a tool called NH-Predict through its subsidiary NaviHealth, now operating under the name Home and Community Care. NH-Predict is built on a database of approximately 6 million patient records. A clinician enters a patient's profile, including diagnosis, age, functional assessments, and physical capacity scores. The system outputs a number, how many days of post-acute rehabilitation care this category of patient statistically needs. That number becomes the operational ceiling. When a patient's Medicare Advantage stay in a skilled nursing facility approaches the algorithm's predicted length, NaviHealth flags the case. Coverage terminations follow, sometimes over the direct objection of the patient's attending physician. The November 2023 federal lawsuit, Estate of Gene B. Locken et al. Versus UnitedHealth Group, filed in the U.S. District Court for the District of Minnesota, alleges that UnitedHealth employees were pressured to keep patient stays within 1% of the algorithm's predicted length. Gene Locken was recovering in a skilled nursing facility when NaviHealth's system determined his time was complete. His doctors disagreed. His family paid for nearly a year of continued care out of pocket until his death. His estate is the lead plaintiff in that federal class action. In March 2026, a federal magistrate judge ordered UnitedHealth Group to produce a wide range of internal documents, and the court specifically cited the Senate's findings about denial rates as evidence that pre-deployment records were relevant. The Senate Permanent Subcommittee on Investigations published those findings in October 2024 in a 54-page report titled Refusal of Recovery: How Medicare Advantage Insurers Have Denied Patients Access to Post-Acute Care. The report found that UnitedHealthcare's denial rate for skilled nursing facility admissions went from 1.4% in 2019 to 12.6% in 2022. That is a 9-fold increase in 3 years, coinciding exactly with the rollout of NH-Predict. Here is the number that explains why the algorithm kept running. In June 2024, NaviHealth processed half of all Medicare Advantage requests for skilled nursing facility admission in the country. It denied 14% of those requests, higher than any other contractor. When patients appealed, the plans overturned 97% of NaviHealth's denials. One large health plan in the dataset received 42% of all skilled nursing facility appeals and reversed 99.7% of its own decisions. These figures are from the HHS Office of Inspector General report published in June 2026, which described the overturn rate as extremely high and concluded it indicated a breakdown happening at that first request step. The breakdown is not a malfunction. It is the model. The algorithm is calibrated to deny. The business logic depends on most patients not appealing. According to KFF data from January 2026, only 11.5% of denied Medicare Advantage prior authorization claims are ever appealed. The remaining 88.5% are absorbed. Patients pay out of pocket, reduce their care, or go without. Cigna built its own version before it sold its Medicare business. Its tool was called PXDX, shorthand for Procedure to Diagnosis. In 2022, Cigna's medical directors denied 300,000 claims over 2 months using PXDX. The average review time per claim was 1.2 seconds, according to internal Cigna spreadsheets reviewed by ProPublica and the Capitol Forum and published in March 2023. One Cigna medical director, Dr. Cheryl Dopke, denied 60,000 claims in a single month. A second, Dr. Richard Capek, handled more than 80,000 instant denials in the same period. Neither of them opened a single patient file before denying. A former Cigna physician described the process directly. We literally click and submit. It takes all of 10 seconds to do 50 at a time. In May 2025, a federal judge in Sacramento allowed class action claims against Cigna to proceed, ruling the company had failed its legal obligation to have a physician individually evaluate each denial. In a few minutes, we will show you exactly what removes this system from your care decisions entirely, and why timing is the only variable that determines whether that option is still available to you. Before we get there, you need to understand the second mechanism, because it explains how these companies post record profits while simultaneously running denial systems with error rates approaching 100%. The denial mechanism and the billing mechanism do not run independently. They run on the same enrolled population, in the same fiscal year, in opposite directions. Medicare pays insurance companies more money for patients who are sicker on paper. The sicker the patient appears in the risk adjustment calculation, the higher the monthly government payment the plan receives. The intent was to ensure plans would not avoid covering high-cost patients. What happened is that the industry learned to add diagnosis codes to patient records, codes that make patients appear sicker than they are, without providing any treatment for those fabricated conditions. This is called upcoding. The Medicare Payment Advisory Commission estimated that Medicare Advantage risk scores were inflated by approximately 20% in 2024. CMS applies a correction, but an inadequate one. The net overpayment came to at least $83 billion for that year alone. The Wall Street Journal examined Medicare data covering from 2018 to 2021 and found that private Medicare Advantage insurers collected $50 billion from the federal government for diagnoses added solely by the insurers to patient records, diagnoses for which the patients received no treatment. The diagnosis existed on the insurance paperwork. The condition, in many cases, did not exist in the patient. The most specific example from that investigation, 66,000 Medicare Advantage patients were diagnosed with diabetic cataracts, even though they had already undergone cataract surgery. It's anatomically impossible, said Dr. Hogan Knox, an eye specialist at the University of Alabama at Birmingham, who reviewed the data. Once a cataract lens is surgically removed, the cataract cannot return. UnitedHealth alone added approximately $2.3 billion in diagnoses in 2022 from in-home visits, diagnoses that led to no subsequent treatment, according to data cited by Senator Elizabeth Warren at a 2025 Senate hearing using HHS-OIG findings. The same patients whose claims for nursing facility care are being denied by the NH-Predict algorithm are also having diagnoses added to their records by that same insurer's home visit program to collect higher payments from the government. The denial system and the billing overpayments run simultaneously on the same person. This is not an accident. It is the architecture. The three companies needed a distribution mechanism to reach Americans turning 65. They needed brokers, independent advisors who would sit across the table from seniors during open enrollment and explain the choices. Those brokers publicly described themselves as unbiased, carrier agnostic, and focused exclusively on matching each client to the right coverage. On May 1st, 2025, the United States Department of Justice filed a civil complaint under the False Claims Act against Aetna, Elevance Health, and Humana, along with three of the largest insurance broker organizations in the country, eHealth, GoHealth, and Select Quote. The complaint alleges that from 2016 through at least 2021, those three insurers paid hundreds of millions of dollars in illegal kickbacks to those three broker organizations in exchange for Medicare Advantage enrollments, regardless of whether the plans were suitable for the individuals being enrolled. Internal communications obtained in discovery document the arrangement directly. When an eHealth executive reviewed Aetna's payment structure, the executive wrote internally that the agreement was not even a little compliant. I'm pretty sure if Aetna got audited by the Centers for Medicare and Medicaid Services, they'd be in trouble. Elevance, then operating as Anthem, paid GoHealth more than $230 million in these arrangements from 2017 to at least 2021. According to the complaint, the Department of Justice further alleges that Aetna and Humana used the kickback structure to pressure brokers into enrolling fewer Medicare beneficiaries with disabilities, whom the companies identified internally as more costly to cover. Federal law prohibits that discrimination. The advisors who were supposed to be on your side were being paid by the companies whose plans you were being enrolled in. The choice you thought you were making was not a real choice. Here is the part of this story that has received almost no attention in mainstream coverage, and it is the most consequential structural fact about Medicare Advantage for anyone currently enrolled. You can switch out of Medicare Advantage. You can return to traditional Medicare. What you may not be able to do is get the supplemental coverage that makes traditional Medicare financially workable. Medigap, also called Medicare Supplement Insurance, covers the deductibles, coinsurance, and out-of-pocket costs that traditional Medicare does not pay. Without it, traditional Medicare has no annual cap on what you can owe. When you first enroll in Medicare, during the 6-month Medigap open enrollment window that begins when you activate Medicare Part B, federal law guarantees that any insurer must sell you any Medigap plan in your state at standard rates. No health questions, no medical underwriting, no rejection for pre-existing conditions. That window opens once. After it closes in 46 states and Washington, D.C., Medigap insurers can evaluate your health history and deny your application entirely. They can charge you higher premiums. They can impose waiting periods before covering conditions you already have. In 2022, KFF analyzed Medicare Advantage enrollment data and found that 90% of Medicare Advantage enrollees ages 65 and older, 22.4 million people, had already lost their guaranteed issue protections to purchase Medigap if they chose to leave their current plan. David Myers, Assistant Professor of Health Services, Policy and Practice at Brown University, described what this means in practice. Once you get into Medicare Advantage, if you have a couple of chronic conditions and you want to leave, even if Medicare Advantage isn't meeting your needs, you might not have any ability to switch back to traditional Medicare. KFF Health News published his finding in November 2024 under the headline, "Older Americans Say They Feel Trapped in Medicare Advantage Plans." The companies know the Medigap window closes. Their enrollment model is built on reaching people before they understand that. If the market is structured to capture you before you know what you are agreeing to, the question is what the people who do know are actually doing. The first option is traditional Medicare with Medigap Plan G. Traditional Medicare is accepted by 98% of physicians and hospitals in the United States. No prior authorization for any Medicare covered service, no network, no referral requirements, no algorithm between your doctor's clinical judgment and your coverage. Plan G is a Medigap supplement that covers your hospital deductible, skilled nursing coinsurance, and the substantial majority of cost sharing under Medicare. What you pay is a monthly premium, typically between $80 and $200 at age 65, depending on state and insurer, and the annual Part B deductible, and nothing else for covered services. You can see any doctor in any hospital anywhere in the country. This is what former Medicare Payment Advisory Commission members who spent decades documenting this market's incentive structure consistently describe as the choice that removes the denial mechanism from the transaction entirely. The critical constraint: Plan G must be purchased during your 6-month open enrollment window. After that window closes in most states, a history of cancer, heart disease, or diabetes may disqualify you permanently. The second option is understanding what that window is and acting before it closes. The 6-month guaranteed issue period that begins when you first activate Medicare Part B is a one-time, federally guaranteed right. During that window, no insurer can deny you any Medigap plan available in your state, regardless of your health history. The moment that window closes, and it closes once permanently, in 46 states, Medigap insurers can ask about your health and reject you. This is the most widely underpublicized fact in Medicare enrollment. Medicare Advantage plans market aggressively during this window with 0 premium plans, gym memberships, dental and vision benefits. They are marketing to healthy new enrollees during the one period when those enrollees have maximum coverage flexibility. If you choose Medicare Advantage during this window, you are trading the flexibility you have now for a plan that works differently when you are ill. The third option is the appeal, and it works at rates the companies are counting on you not knowing. The HHS Office of Inspector General's June 2026 data shows that 95 to 97% of appealed Medicare Advantage prior authorization denials for skilled nursing facility care were overturned. The overturn rate at some individual plans exceeded 99%. The appeal process has 5 formal levels. Most denials are resolved at the first or second level. A peer-to-peer review, your attending physician requesting a direct conversation with the plan's medical director, resolves many cases before a formal appeal is necessary. The plan's denial process is designed on the assumption that 88.5% of patients will not contest the decision. The data shows what happens when you do. This is not only a Medicare story. The architecture is the same one that runs through paint, power tools, boat engines, and eyewear. When 3 corporations buy up enough competing brands in a market to present the appearance of consumer choice while eliminating actual competition, and then use that position to simultaneously extract more revenue from the payer while delivering less value to the end user, the mechanism is identical regardless of the product. When Luxottica acquired Ray-Ban and Oakley and sold them as competing brands, it was the same structure. When UnitedHealth, Humana, and CVS Aetna built Medicare Advantage into a 59% controlled market, they applied the same logic to a program that covers 32 million people's healthcare after age 65. The choice you think you are making is not a real choice. Check who owns the plan. Check whether you are still inside your Medigap window. And if you have already received a denial, check the appeal data before you accept it. This is what Policy Exposed does. No affiliate relationships, no sponsored plan recommendations. Every source is linked in the description. If you received a Medicare Advantage denial for skilled nursing or rehabilitation care and want a step-by-step walkthrough of the 5-level appeal process, that is the next video on this channel. Subscribe if you are done being the person in the room who does not know how this works.